Okay, everyone. Sara, I'll join you. Sara. I just wanted to welcome you for this is our third, isn't it, research networking event that we've done in this way. And as part of the Centre for Neuro Rehab, so welcome. We were just wondering whether or not this was quite early after the festive break, but and actually we had nobody's show, but actually people trickling in, so that's good. And you can ignore the one if you're doing dry January. So again we're going to do a similar format to what we've done before, in that we've got presenters who give a 7-minute presentation. There'll be a chance for a couple of questions, but what we love about these sessions is the opportunity at the end where we'll move people into different corners of the room and outside, so that if there's a particular speaker you want to go and have a discussion with, then you can. And then there could be some interactive small group discussions as well. We've done it a few times now, and it's worked really well. I think people quite enjoy that. Or you can just go and have a glass of wine. But we would like some discussion, if that's all right, because the reason why we're doing it like this, and where the beauty of what we've found in the past, is that when you get a mix of clinicians, academics and clinical academics, sometimes that's where some great discussions and sharing of ideas and bringing together ideas can happen, you know, for perhaps even future research ideas. So that's the aim.
Yeah, brilliant. So just to say, one of our speakers unfortunately can't be here in person, but they wanted to give their talk, so they're going to be online, but it means obviously from the networking point of view that would be more challenging, but we've said we'll take, you know, we've got their email addresses on, so if anyone really does want to kind of, check in with them, it's really just about inspiring you by different people's methods, and and taking the opportunity to talk through things with them and learn from each other.
I think we've got a good range this time, so great. So our first speaker is Nora Brennan, who's a neurophysio at Headway. Nora, and so she's going to speak about the brain injury survivors' experience of accessing mental health services in North East London. It's a qualitative study. Go ahead, Nora.
Hello, everyone. My name's Nora. I'm the Therapy Service Manager and Neurophysio in Headways London. I'm here today to present one part of a mixed method study that we did in 2023. That was part of a grant application that we applied for to look into health inequalities. So I'm just going to present the qualitative component today. 7 minutes is very short. And also I'd really be keen for people to get involved. So this is a bit of a call out as well for anyone who's keen and interested to be involved in this project going forward, because there's lots of opportunities going forward. So like I said, we had some grant funding to look at health inequalities in our catchment. We cover 13 boroughs in North East London. And what we initially started looking at was neuro rehab services for our members. And then through speaking to members, speaking to clinicians, we decided to narrow it down to mental health services. So looking at free to access psychological services for brain injury survivors. And what we found was it was very limited, as you can imagine. And that really kind of tied in with the literature in terms of the national unmet need psychological therapies. So the literature talks about it being 3 times more prevalent post-brain injury compared to the normal population. I would think it might be more. So Headway UK did a national survey last year that said 70% of people post-brain injury reported a decrease in their mood. So potentially it's higher. It did include MTBI as well, so it could be, a little bit different. But I think, we've all seen it. It could be a bigger problem than is noted in the literature. And we looked a little bit into the impact of intersectionality. So looking at people who traditionally are less likely to engage in mental health services, so people from ethnic minority communities and marginalised communities, and wondering if that had an impact as well, because they make up a big part of the brain injury community as well. So we started off with a service audit. We looked at free to access services that offer standalone psychological therapy. So we looked at local community services, we looked at talking therapies, and also we went to Mind as well. So did a service audit across those. The outcomes of those, then we decided we wanted to understand the experiences of people accessing those services. So that's going to be the focus of today. So we did 5, that's gone a bit funny, hasn't it? So we did 5 groups. 2 of those were online across all of our services within Headways London. 17 people came, and it was a really diverse mix of people. So in terms of diagnosis, age, years since injury, also in terms of ethnicity and socioeconomic status. We were really lucky to have a good diverse mix of people. And then we took that and analysed it using thematic analysis. And again, oh dear, that really didn't translate very well. You can see some of it's gone off the bottom of the page, but I'll explain. So we came off with 3 main themes. So one of was around access and accessibility, professionals' understanding of brain injury, and changing needs over time. So a lot of these will feel very familiar. So in terms of access and accessibility, that's talking about accessing the services in the first place, and then accessibility within the service, so within the treatment itself. So people talking about the reliance on generic services, not understanding the brain injury, not making any adaptations to the referral process, the assessment process, to the process itself. So people forgetting appointments, getting discharged, forgetting what they've done in the previous session. Also the impact of the physical space, so people talking about being in these very dark basement rooms, no natural light, being quite triggering for people with PTSD, for example. People not being able to get in or out of buildings if they were in a wheelchair, so feeling quite trapped. And also the impact of unconscious bias, so people feeling they weren't being referred into services appropriately. One person said that they were seen as an angry black man. That was just his experience every time he tried to get support. Professions' understanding of brain injury, so thinking from GPs all the way through. So the over-reliance on medication, people felt that they were their GPs didn't understand their brain injury, and they were being given medication that actually made them feel worse. It made them feel quite drowsy. They couldn't engage in things that were important to them. And also trying to fit into this treatment protocol that they felt like they didn't fit into. They couldn't fit into what they called this box that they were supposed to fit into. And a lot of people found that trying to fit into these very kind of tight protocols actually made them feel worse. A few people said that they felt like their brains were broken because they were told that their thought processes weren't right. They should be thinking in a certain way and now they're not. So they came away feeling worse. And then the limitations of time limited intervention as well came out. And then I think the thing that really stood out to me was this changing needs over time, because this isn't something that we see in the literature. The literature is very focused on the kind of rehab phase. It's focused on the first 1 year, 3 years. Post 3 years, there's very little around mental health and brain injury. So people talked about the initial phase, the most important thing being around psychoeducation for them and their families. And then what happened was once they got discharged from specialist services, they felt like they fell off a cliff. They started to realise, okay, this is now me. This is me now. Like, who am I? I can't do what I did before. My roles have changed. I'm now being cared for. I'm not a carer. I can't work. And that's when they needed the support. And that's when they were reliant on generic services that couldn't really support their needs. So, and then again, later on down the line, when potentially there's breakdowns in family relationships, in family dynamics, and as any of us would need to access mental health services through our lives, and people are reliant on these generic services that just can't meet their needs. So for me, this was a really important one that came out that I've not seen anywhere before. But like I said, this was a very small pilot study. It was 17 people. What we're trying to do now is trying to pull out some of these themes. We're working with some students in Anglia Ruskin to look into the idea of access and accessibility. So we're going to do some work with therapists and with survivors, looking at facilitators to engaging in therapy. So very practical things. So we're going to do some in-depth interviews and then develop a survey that we can send more nationally. And then we're going to look at, a separate project's going to look at, we've had a therapy service within our day service with providing accessible therapies to our members. And that's been going for 10 years now, working with trainees. And we're going to look at the impact of that. So not just therapeutic outcomes, but the actual impact that's having on people's lives, interviewing them, interviewing their families, carers, but also interviewing staff that work within Headway and just seeing that knock-on effect on our community as well. So that's another project to come out of it. And then the future projects, we're hoping to focus a little bit on this changing needs over time, because I think it's a big gap. And also these intersectional barriers that people are facing. So this double disadvantage that people are facing when it comes to mental health and brain injury. So if anyone is keen to be involved at any stage of any of these projects, it's very early days. So please come and speak to me after. Thank you. Oh no. Oh no. I thought we'd done.
You just want to say a bit more about how you would like people to get involved in the project?
Yes, so we're currently developing some research projects with Anglia Ruskin and with the creative health. There's somebody doing creative health masters who's going to do a project with us. So we're going to be doing a call out for participants. So we're going to be doing a call out for psychological therapists, so whether that's neuropsychologists or psychotherapists who work with brain injury survivors, to be interviewed and also to fill in surveys as well. So that's one element. That we'll be looking for participants, and then we'll be developing some of this work. So we're trying to build a bit of a database of people who are interested in the work. We did do some surveys with professionals, so the focus groups led to surveys with professionals, and I'd really like to look into that a bit more because it shows actually the knock-on effect. If somebody doesn't have the mental health support and the psychological support within their rehab, the knock-on effect it has on every other therapist, every other member of the team. Even within Headway, the kind of non-clinicians, so the key workers, the support workers, and the impact that has on them as well. So that's something that we maybe want to look into a little bit more. Yeah.
Thank you, Nora, and there'll be an opportunity for people to have more of a discussion a bit later.
Yes.
So that's great. Thank you very much.
Sorry. Okay, so next up we've got Kate Sampson, who's a research physiotherapist at UCL Gatsby Computational Neuroscience Unit.
Thank you. Hi, so I'm Kate. Thank you for the introduction. I'm Kate, research physiotherapist, and I work in the Computational Movement Disorder Lab here across Gatsby and the Institute of Neurology here. So today what I'd like to talk to you about is some research that we're doing looking at patients with dystonia and their experiences of accessing rehabilitation. I'm going to take you through a few different methods that we're currently looking at. So for those of you that are unfamiliar with dystonia, dystonia is the third most common movement disorder after Parkinson's disease and essential tremor. My video sadly isn't working, but it is estimated to affect over 100,000 people in the UK and can present in a range of different phenotypes. So more of a focal presentation just affecting the neck, for instance, or more generalised presentation. This current treatment approaches to this condition include botulinum toxin and pharmacological intervention, with second-line treatments including neurosurgical intervention like deep brain stimulation. But where does rehab fit within that? So this graph here on the right-hand side demonstrates that we can see DBS, botulinum toxin and pharmacology, all are featuring very highly within the literature, being mentioned. However, physiotherapy is kind of a poorer cousin, not being mentioned quite so frequently. And although the National Neuroscience Advisory Group recommends within the dystonia pathway that neurophysiotherapy should feature, little is actually known about what patients' experiences are of this. So therefore, what we decided to do was to complete a survey of patients in the UK that have dystonia in order to try and understand this. So we had a survey which was online, which was completed by 181 patients. This is preliminary data, it closed yesterday, but it went from August until January of this year. And 73% of patients that participated were women, with 55% being of the cervical dystonia, which is the most common phenotype of dystonia. And when we look across the 4 nations of the UK, England was kind of the greatest proportion, making up 75%, with Scotland 13%, Wales 10%, and Northern Ireland 2%. So what we wanted to try and do is understand, 1, what is their access like? 2, what is their experience? And 3, what would they like things to look like in the future? So when we asked them about their access to physiotherapy, 62% of patients had not seen a physiotherapist since diagnosis. And when we explored the barriers to this, 76% reported that they had never even been referred, and 33% said they were not even aware that physiotherapy might be of benefit to them. when we asked them about their satisfaction with access to physiotherapy, unsurprisingly, those who had been referred to physiotherapy were more likely to be satisfied, whereas those who had not been referred to physiotherapy were more likely to be dissatisfied, either on an extremely or significant level. When we then went on to look at non-motor symptoms, it was apparent that actually physiotherapy isn't the only thing that's missing from part of this recipe. 82% of patients were reporting that they had pain. However, only 8% of patients were being referred to pain management services. Patients reported in quite high percentages fatigue and cognitive symptoms, but only between 6 and 8% of patients were being referred to occupational therapy. And over 50% of patients were reporting problems with anxiety and low mood. But again, that didn't translate into referral to psychological therapies. Only between 6 to 8% were being referred. So there's a fundamental missing piece here as well, not just for physiotherapy. And then when we asked them about looking to the future, do we think it's important to be referred to physiotherapy? 78% said they thought it would be important. And 20% that were not sure, when we asked them further, well, why is that? They said 59% said, well, we don't really know what physiotherapy can do. We don't have the information about what the benefit might be. So you can see that already people aren't being referred. Patients don't really understand, whether clinicians also perhaps don't fully understand what physiotherapy can do. So there's lots of work to do there. So this then took us on to think about, well, within the literature, what does it say that physiotherapists are doing? So we did a scoping review looking at physiotherapy and found that cervical dystonia and task-specific dystonia were the most common phenotypes being investigated. So I'm going to talk specifically about cervical dystonia here. What we found was that there was so much heterogeneity across all of the studies. So the table here on the left shows all of the different terms that were described in interventions. They were all very poorly defined. They were not really described at all, which makes it really hard to then identify, well, which ones are the most important units that we need to consider within rehabilitation. And to support that further, doses were all very different, and also the outcome measures that were being used were all very different. So it makes it really hard if the units are poorly described. We're measuring them in very different ways, and mechanistically we don't really understand what physiotherapy is really doing. We don't really have that. A lot of clinical practice is kind of based upon what we normally use with patients as neurophysiotherapists. This image here just represents within the literature the most common things that were described, which were stretching, movement retraining, postural re-education, which is I think what lots of clinicians would instinctively use. However, we know when surveying therapists that are working with patients with dystonia on quite a small scale level, physios are either working as injectors within botulinum and toxin services but not able to provide the rehab, or they're working in outpatient neurophysio services but are not providing the Botox. But there's nothing kind of bringing those two worlds together. But we know that physiotherapy can optimise the effects of botulinum toxin. So where are we going next? So, well, my lovely video may or may not work. Let's see. So when looking at all those different units, what we've decided to try and explore is the use of visual feedback or augmented feedback for rehabilitation approaches. This is slightly different to what some of the other studies are doing, but we're building on kind of some of the smaller studies. The thought process is that at the moment, therapists are working on full neck range of movement to sensory reference points. But actually, we don't use our full neck range of movement within functional activities. We only use 20 to 40%. And so therefore, our thought is, could we try and use different methods to try and improve neck range of movement? So this is visual feedback using a laser. It's a bit more fun because we've got these interactive elements where the laser can interact with them. And we can also try and gamify this slightly with the hope to try and expand this perhaps into other forms of AR or VR in the future. So next steps for us is, I guess, exploring this method further. And we'll also be thinking about ways to try and promote the benefits of physiotherapy. just a thank you to our collaborators, Dr. Sadnitska, and Dystonia UK, Dystonia Europe, and other collaborators. Thank you.
Brilliant, thank you so much. So wait, hold on, we've got a couple of minutes now, just to see in case anyone has any questions that they'd like to ask Kate from the audience. One at the back, yeah.
So that's really cool with the gamification at the end. I really like that idea. When you're talking about VR and AR, are there constraints in terms of the technology? Because they tend to be a bit weighty sometimes, the headsets and things, and that might
Yeah. So this is very like in its infancy. So this is a device that's mostly being used for patients with whiplash. So very kindly, a company in America have loaned us the device. So we haven't really explored the kind of full potential, but that is hopefully something that we could explore a bit more to try and bring in more naturalistic movements and not just, you know, if we could be turning to cross a road virtually, that would be far more functionally applicable than moving a light. So yeah, the future would hopefully encourage that sort of stuff.
And one more, yeah. Go for it.
So if you could persuade all the clinicians, by which I guess you mean doctors, to refer anyone who is appropriate for physiotherapy, are there enough physiotherapists?
I think that's a really great question. The answer is probably no. There aren't enough physios. I think if we just take this hospital, for instance, 500 patients with cervical dystonia are seen every 3 months for botulinum toxin. I'd say a very, very small percentage are seeing a physio. So there is many gaps that are not fully catered for at the moment, but we know that lots of other neurological conditions you're referred. So why is cervical dystonia different from that?
Particularly because there could be a cost saving if it means that's because the stocks of botulinum toxin. But the first ever paper was in this. We were able to expand the gap in between injections. So there is potential.
Something like that seems such an obvious.
Yeah.
You kind of almost assume that that would be part of the service, but it's not. Though.
And I guess if you think about spasticity services, it's very naturally multidisciplinary.
Yeah.
There's both, well, here in our hospital perhaps there's multidisciplinary, but unfortunately for some reason dystonia isn't the same. It's not treated quite the same, but I think that's something that would be good to try and explore changing.
Great, thank you.
Thank you. Great. So I'd like to then welcome Hubin Zhao, who is going to speak to us on wearable intelligent neuroimaging for health and beyond. So you've got 7 minutes. Thank you.
Great. Thanks a lot for the intro. I'm so sorry cannot make in person. I'm a bit of a while, so better stay at home. Brief intro about myself. I'm a lecturer in medical technologies, and this is primarily about my background and about my independent research group. In short, I'm a technology person, so don't know too much about clinical. That's one of the reasons I'm keen to join the event. I want to receive advice, feedback, and possible collaboration opportunities. So I built my group about more than 3 years ago. It's relatively young but fast-going group. And then talking about neuroimaging technologies. So we all know functional MRI, which can be used like a typical functional neuroimaging technology, which can be used to assess brain function to get a high quality 3D brain imaging. The consideration is really about the size of the device, and also it's relatively expensive, and it's really requires the subject or patient remain stay in the device. Another technology is also more and more popular is EEG, which can measure the brain activity from the scalp. And also there are low-cost wearable technology of EEG is available in the market now. The consideration is mainly the capacity of imaging, particularly if we can get deeper brain information with steps. It's probably a bit of difficult for EEG. Actually, we also found we can also use light to investigate brain function, and the basic principle behind it is the brain tissue is relatively transparent to light, so the light and the near infrared can be penetrated into the scalp and back again. Then the primary absorber of the near infrared in brain tissue are hemoglobins. So the near infrared spectroscopy is sensitive to brain oxygenation. At the same time, brain oxygenation is close linked to brain function. So the application of near infrared spectroscopy is called FNIRS, which is the fundamental technology I'm talking about here. And then the technology I'm particularly interested actually is a more advanced offshoot extension of FNIRS, which is called diffuse optical tomography. We use like much dense like sensors, then we can use DOT to produce brain imaging, and the high density DOT technology has the potential to approach into functional MRI. So some study did by a US group about 10 years ago is demonstrates the technology have like a strong overlap with conventional functional MRI. But technology-wise, as a technologist, the point is like in recent 10 years, no matter the benchtop and wearable device, most of the device use a fiber, which makes the technology in large size, cumbersome, and also like got limited measurement channel because in the limited area of the scalp, the number of fibers we can put on is limited. So the question for me is really to how to get off this like a conventional structure and to make a truly viable but high density DOT technology that can be used for brain height. Then at UCL, we propose a different concept is based on the modularity. So in this architectures, a DOT system can be formed from an independent image module. For example, like this is a single one, we can like around like 8 to 12 image measurement channels with a linearly increase the number of modules, then we can exponentially increase the measurement channels. So for example, like I lead the development of an old system, it demonstrates like more than 1,000 channels. So just some quick reference, typically the channel number in the field is in the range about 1 to 50. It's difficult to reach about 100. At the same time, we maintain the weight about the technology is only about 300 grams, which is truly, although not perfect, but truly viable for adults. Then after the development, we demonstrate some unusual pattern. So we ask a subject to working at texting, which to mimic our like nature realistic behaviors. We try to push forward the technology. It's not only in conventional like well controlled lab, but also in like in our daily life for like a rehabilitation assessment, for personalized health monitoring, etc. So it demonstrates like a clearly like an overlap between the comparative study, which is seated texting, when people working texting. So in UCL campus. At the same time, like when we're talking about, okay, this is functional neuroimaging, but like how far is away from the golden standard of brain imaging, like MRI. So we demonstrate like some study from like an old functional MRI study. We can find actually we can use our device doing something similar. But like to make it clear here, we don't have like an intention to compete with functional MRI because like the resolution of functional MRI is much, much higher. So some number like in terms of spatial resolution for this study is in the range about 1 to 3 millimeter. Like for our device, it's only about 8 to 10 millimeter. And also the depth is also limited as well. We can only measure up to 3 centimeter inside of brain. However, we try to push the technology to cover some application. It's not easy to be accessible by functional MRI. To do that, we're also trying to use different like AI technologies to further make the device smaller, faster, and smarter for different applications. Try to achieve like real-time processing and reconstruction of the imaging. And apparently, it can provide an avenue for different translational applications such as a BCI, HRI, and some like ongoing project like early diagnosis of cerebral palsy of infant. And also I'm very keen to do some like a stroke application. I got some ongoing project for stroke application and also collaborated with some member in CNR such as Nico White and also other colleagues for other stroke-related application as well, potentially, hopefully, to do stroke classification and stroke rehabilitation simultaneously. So, like looking forward, like one thing is probably is quite ambitious, but I'm really keen to do is not only to put the device on the brain, but also on the muscle, and also not only the optical one, and also can integrate other modalities such as EEG or EMG on different position to not only to look into the brain function, but also to look into the correlation between brain and the muscle based on the principle of cortical muscle coherence. And hopefully this can get some real world impact for a stroke application and beyond. It's limited by time. This is really a brief high-level intro about my research interest and direction, and hopefully this is a starting point to open more collaborations. So a quick acknowledgement for different funding bodies, and thank you so much for your time and listening. Very happy to take questions if you have any. Thank you.
Thank you. Wow. Okay. So I think it would be such a shame not to give you the chance to get some questions. So if anyone does have any questions in the audience, then I can repeat it back. So hopefully then Hubin can hear. So does anyone? I think I'm pretty sure that when you mentioned them being able to measure the kind of the muscles as well as the brain, I'm pretty sure that some people's ears pricked up in the audience. So anyone?
Yeah, that was my fault actually, because one of the limitations we have looking at muscle function in muscle diseases is looking at activations within scanners and within equipment. So something like this looks like it's in a more naturalistic environment. So has there been any work correlating it with some of the more traditional spectroscopy techniques for muscle imaging?
Hubin, I don't know if you caught that question.
Yes, I think
Okay.
I briefly get the point, and feel free to correct me if my understanding is wrong. Yeah, I think it's a very good question. This is something I'm also thinking quite a long time as well. So this one we are not looking on is it's based on the near-infrared spectroscopy. So this is a base, but the difference is we are trying to. For brain is we got 3D brain imaging, and for muscle one advantage is we can get a multi-channel. So it is even in the muscle in a limited of number of modules we can get 15 to 100 channels. So which is we got multi-channels. We got potentially we can get some special information inside of the muscle, and with different regions, we can hopefully get the correlation between in the muscle, but from different area of the muscle. And then the further step is more ambitious, also with some uncertainties. We can also trying to get some muscle imaging as well using a device. So a two-P student is currently working on is hopefully ideally we expect to get some three-dimensional imaging about the local muscle activities with a range in 3 centimeters, and can give us more information compared to the conventional technology such as EMG or other technology for that. And then further on that, as I briefly mentioned, is I think it's already a lot of brilliant research is coming up. Is looking to the CMC, is looking to the correlations, how the link between each other. And by this technology, we hope we can get more clear information in a nature realistic task, how brain and muscle to interact with each other. Hopefully can give some implication for rehabilitation applications. Not sure get your question correctly and gives a
brilliant.
Answers for that.
No, that's really helpful. Thank you. I mean, I think we're running out of time, but it's just. Did you mention that you are collaborating with some people already?
Yes, I'm initially working on Nick Ward. I'm not sure he's here or not. Yeah.
Okay.
He's here. That's great. Hi, Nick. Sorry, I cannot make it. We submitted a proposal a couple months ago, but that one is primarily focused on brain, and we are trying to do more. Is more ambitious. Is working on cortical muscle coherence. Yeah.
Okay. Well, watch this space. So I think we'd love to have you back at some point. So thank you so much.
That'd be really great. Thank you so much.
Thank you.
Thank you.
Just while we do this, swap over, our next speaker is Jodi Allen. Oh, you look too relaxed there, Jodi. So, Jodi is a speech and language therapist, and she's a NIHR clinical doctoral fellow as well, doing her PhD. And she's looking at quantitative ultrasound, size and echogenicity analysis to evaluate changes in the muscles involved in chewing and swallowing in people with myotonic dystrophy and others, I think.
One second.
I should make the title longer, shouldn't I?
Oh, yeah, well, tested me.
Hi guys, as Gita said, I am a speech and language therapist representing the profession, and I'm sticking on the theme of imaging actually. I'm going to talk to you about, very specifically, quantitative muscle ultrasound, which is a method or a technique I've used as part of my PhD. So let's go. Okay, so for those who don't know, speech and language therapists are experts in the differential diagnosis and management of dysphagia. But the limitations in our assessment tools mean really we're only able to evaluate symptoms, maybe by nasoendoscopy, or swallowing biomechanics via X-ray. One of the challenges of these techniques is that we don't ever really understand true pathophysiology. So, for example, we might see biomechanical movement of the hyoid during the swallowing in a patient with Parkinson's, and the same biomechanical change in a patient with peripheral neuropathy. But what we know and hypothesize is that the pathophysiology is very different, but we're not able to refine that diagnosis any more deeply, and therefore our therapy is not particularly targeted to the pathophysiology. So guess what? So I'm going to talk to you about quantitative muscle ultrasound because it's, for me, it's really given me as a speech therapist and researcher now an opportunity to really get into what is going on into those muscles. And my particular area is neuromuscular disease, so that works really nicely because we're looking at the peripheral nervous system. So let me talk to you about quantitative muscle ultrasound and see what you think about this as an approach for your patient group. So for those who are not particularly familiar, it's something that probably has been seen as the slightly poorer cousin to muscle MRI. We use a lot of MRI here to look at our muscles in neuromuscular conditions, but actually the teams over in the Netherlands are big advocates for muscle ultrasound, and you don't need me to point out the differences between using an MRI machine, which can be challenging. We can't refer into it for starters. It's big, it's costly, and for an ultrasound, it is simply a laptop and a probe and a clinician. So I'm particularly looking at the muscles related to chewing and swallowing, but of course it's applicable to all muscles throughout the body, as long as they're superficial enough for the ultrasound to penetrate. So as part of my learning, I had to learn quite a lot about ultrasound physics, because if you don't understand the basics, you're going to really skew your imaging. So essentially we're placing the probe over the muscle. In this one, this is me placing it over the floor of mouth muscles. So we're imaging the genial hyoid and the anterior belly digastric, which is involved in hyoid movement. And then with that, we create some images. So on our images here, we've got those exact muscles that I've talked about. So we've got the anterior belly digastrics, which for me are the teddy bear ears, so it looks a little bit like Mickey Mouse. We've got the teddy bear ears here, the anterior belly, and we've got the genial hyoid. And what we do is at the moment, we're in the realms of hand drawing, but AI is starting to help us out with some of that muscle delineation. There's a project already at Queen Square looking at that. And we hand draw around the muscle and we get a grayscale score. So we move from black being representative of muscle, and the whiter it gets represents greater fat infiltration or fibrosis. We can also then get the thickness measurements and cross-sectional area of the muscles. So for my PhD, I've collected a whole host of normative data of patients between the age of 18 and 70 to look at what that looks like normally in a group of patients. So this kind of data, I'm in the depths of statistical analysis at the moment, but this is the early data of the healthy controls and a little bit of an insight into what we're seeing in the patient groups as well. The patient group that I've studied are patients with myotonic dystrophy. And if you read the textbook version of that disease, they tell you it's a disease of the muscles. But then if we know anything more than that, we know there's central nervous system involvement, and there's also myotonia. So as a speech therapist, we really need to tease out which of those is contributing predominantly to the dysphagia. So, what are we seeing here? So you don't need to look in any detail. All you need to know on this graph is that the females are in the red and the males are in blue. And we're seeing that in the healthy group, females tend to have greyer muscles than the males, suggesting that actually we've got more fat infiltration, would you believe? Hey? And then we have also got same idea in the healthy muscle. We're looking at the thickness scores, and even in these small bulbar muscles, we're seeing differences between males and females in the thickness of the muscles. So the females in the red again, males in the blue, we're seeing that there's actually a reasonable mean difference between males and females. And then if you start looking at how that correlates or looks in the patient group, so these are Z scores, the patient group would sit at 0, and we're seeing in mild, moderate and severe disease that we are seeing an increase in grayscale of the patient group, suggestive of fat infiltration and fibrosis. Same again with the patient group. With in the patient mild, moderate, severe disease, we're generally seeing a trend for the muscles to get thinner in the patient group as the disease progresses compared to the healthy controls. And one of the questions I've always wanted to know is that grayscale really representative of fat, or is it something else? So we had some patients, let me just show you those images. So these are, for those who are not familiar with muscle ultrasound, hopefully you can actually see just the visible differences there between the normal or healthy control and the masseter of a patient with myotonic dystrophy. So it's thinner and whiter. And then we popped 18 of the patients. So we had 94 patients in the study and 18 of them consented to a muscle MRI. So we've popped a linear regression line between the ultrasound grayscale and the fat infiltration. And you can see that as a general rule, they both correlate. So in summary, it is possible to use quantitative muscle ultrasound even in the really small muscles of the head and neck. The early evidences or the data so far is suggesting that there is, we can differentiate male and female, but also more importantly, we can differentiate between healthy and diseased muscle. We do need to pay greater attention about the reliability of measurements, because there's plenty of room for measurement error with ultrasound, as you can imagine. And the next stage would be to correlate what we're seeing with the muscle pathophysiology with actually what's going on biomechanically and symptomatically for the patient group as well. So that's hopefully the data we'll have in the next couple of months. So thank you very much.
So, no, don't run away. Any questions?
Jumping way ahead to clinical application, you often see a couple of speeches pushing the fees down the hallway. They've had boatloads of training. Is this something you envisage, that side where you said you had to do lots of physics, essentially become a sonographer? Do you feel that side will be able to be eased off as well at the point of clinical application, or do you think it's still going to require all of that training and it's just a device that will be much more accessible?
Yeah, I think that's a really good question. One of the great things about muscle ultrasound is that once you've set your machine up, once the people who know this physics have set your machine settings don't change. You can't change them because then you change your grayscale. So actually, once your machine is good to go, theoretically you can take it out onto the wards, and the training is more about probe placement and angle. So in principle, yes, it theoretically should add to our toolbox of diagnostics.
I might jump in chair's prerogative with a quick question, even though I'm obviously involved with your work. But I know you've only done the initial analysis with the patient group, but are you planning to account for the male-female differences in that cohort? Yeah. So are you going to do some matched analysis with that?
Yeah, so we basically we've done some regression analysis on how sex, age and BMI impact muscle as well. And interestingly, I wasn't sure it was going to be big enough to see a difference, but you are seeing differences across all of those domains.
Interesting. Anybody got anything else? Okay, well there's more opportunity for questions later for Jodi.
So I'd like to invite our sixth and final speaker to come and talk to us about the Octopus trial in MS. So we just thought this would be a fascinating thing to hear about in terms of complexity of interventions. So thank you very much, Sure.
Yeah, no, thank you very much. For the complexity, I'll try not dive into too much of the boring details of it, but let me just see. So, I'm Sean. I'm one of the clinical fellows working on the Octopus trial with Professor Jeremy Chataway. So I'm going to give a little bit of a background first because there's a lot of novel names being tied into this trial and other ones which are similar to it. So it is a adaptive platform multi-arm multi-stage trial. What that means is that since it's a platform trial, it's not focusing on testing one particular drug, it focuses on the disease itself, in this case progressive MS, and so all the machinery is geared towards testing as many things as possible to optimize finding a or multiple effective treatments for that condition. It's adaptable, which means that there are certain elements within the trial design that can change over the duration of the trial because this is going to be exceptionally long, so we're talking like 10, 15, 20 years long. And lastly is that it's a combination of all of these. So it'll just involve all of them being bundled together. This just gives a bit of an idea of how we're going to be comparing them. So the first box and the last box, where we're just saying this is a trial that will enable us to test multiple interventions against one control at the very beginning, and then adding on more arms as the trial progresses, as opposed to how we traditionally do things, which is where you simply have one drug versus one control, and you just have multiple trials all testing this in their own way. This is the pathfinding model, so this is a separate multi-arm, multi-stage trial that was conducted that we're basing how we're building Octopus off of, and the reason is because it's been highly successful. So to give a bit of an example over the next few slides, this is how it started. So it was a multi-arm, multi-stage trial in prostate cancer, trying to find effective new treatments for that. It had several decades history of no new effective treatments being discovered, and we see that over time, we add on more arms coming in later, drugs progress from one stage onto another, and ultimately we end up with something like this. So Stampede is actually going to be concluding in the next couple of years, and when it started off with 6 arms and one control, you add on 5 arms multiple years later, and ultimately it's ended up with an enormous number of participants taking part in multiple changes to standard of care with a tangible difference in the survival benefit for these patients. So this is a bit of a broad overview of Octopus and how it's being set up. So it's progressive MS, very broad inclusion criteria, ages 18 up to 70, wide range of disabilities. So for those not familiar with the EDSS, it means people who are quite ambulant to those who are completely wheelchair dependent, but still have some upper limb function. And these are the 2 stages in which it's broken down. So the multi-stage component comes in here, where the first stage is dependent on MRI scans, so whole brain atrophy, and the final outcome will be the clinical measures that we always use to determine whether or not a new treatment has become effective. In terms of thinking, again, a step back on the benefits of conducting a study like this. So this very helpful paper that had come out had conducted a lot of simulation studies to basically say what are we actually gaining by running it this way. And here we can see the benefits of a setup time. So the top panels are showing how long it takes to set up one of these platform trials versus a traditional 2-arm trial design. And we can see that maybe predictably it's a little bit longer to set up one of these studies because it's much, much more complex. But then in the bottom run, we see that then if you compare it to setting up, say, 10 individual studies, whereas one study like this will easily test 10 drugs in its own lifespan, then you see enormous gains and enormous benefits in terms of how long it actually takes to set up. The same can then be said for the cost. So here on the graph on the left-hand side, you can see in the orange color is a single platform study and the probability of how much it'll cost, and the really faded light blue on the other side will be individual drug trials, which is what we normally see. So there's a very tangible, very likely chance that it's going to save a lot of money in the long term as well. So just taking a step back now and just thinking about Octopus specifically, how it's been designed and why we've designed it this way. So this is what we call the interim outcome, so the stage 1 analysis, where we're looking at whole brain atrophy. What we're doing is undertaking an MRI scan at baseline when people are randomized and 18 months later, and checking how much the brain has shrunk in the interim. And that we know from multiple previous studies is a good indication of how people's disease is progressing over the long term. And then we can use this to give us that early signal if a drug is likely to at least be doing something. So you're not going to be as stringent with it as you would with other drug trials, for example. You're quite liberal in your opportunity for getting a false positive, but that's baked into the statistical analysis and the way in which these trials are more successful. Because what you don't want is a situation in which none of your drugs are going through. It's better to have 1 or 2, even if they ultimately prove to be fruitless, to go through, because it keeps all the machinery going. It keeps it much more efficient. And this is just highlighting, this was all conducted from analysis of multiple previous studies. And then lastly, this will tell us definitively if a drug is or isn't working. So the EDSS, like I mentioned, is our go-to typically for measuring disease progression in people with MS. But this composite score, which gives us a more granular aspect of walking ability from the time 25-foot walk and an assessment of upper limb function, means that we have many more events that happen over the course of the study. So again, it makes it much more efficient for determining whether or not an event has happened, whether or not someone's MS has gotten worse. And thinking about the drugs that we're bringing on, so with Octopus opening, we brought on 2 drugs to begin with. The mechanisms that we're looking at are different than most other drug trials in MS. So multiple sclerosis typically is an autoimmune inflammatory condition. So most of the drugs, all of the drugs available really for it are attacking that side of the disease process. We wanted to focus on remyelination and neuroprotection, and therefore both of the drugs that we're using at this moment are focusing on that. So one is racemic mix alpha-lipoic acid, which in the UK is available as a health supplement, but we're using very super high doses of it. There was a previous study in Oregon which showed that it does have a benefit in reducing brain atrophy rates, so it looks promising as a starting drug. And the next one is metformin. There's been an enormous amount of interest in this across multiple different disease groups, and from the MS side we believe that it probably will protect myelin that exists or enhance myelin regenerative capacity in patients with progressive MS. Now, like I said, for a trial like this, you need an enormous number of participants. So I didn't really dwell on it too much, but for the first stage, you need about 125 participants per arm. So that means that for each of these drugs, you need 125 people for the MRI phase and 125 in control. And that all comes to a total of 600 per arm for your stage 2 analysis, your thing that will definitely tell you if the drug is working or not. And so we're saying already with these 3 arms, so metformin, lipoic acid, control, 1,800, and every other arm that you add on is theoretically another 600. So you need a huge pipeline of people coming through, being available for this trial for it to work. So towards this end, there's been a lot of work with the MS register. Patients don't have to wait for someone else to refer them to us. They can sign themselves up basically to gain access to the trial. And these numbers were the original ones where we had over 2,500 registrants, many of them basically going through this initial phase that pre-screens them on the site itself and then go through to the individual trial teams to be able to contact them and see if they can take part. These are the more recent numbers, which I just got. So we've had over 6,000 people registering to come onto the trial, and over 3,000 of them are eligible to take part. So even conceivably with the drug arms that we have right now, we're unlikely to be in a situation where we're not going to meet our recruitment targets. Towards that end, this gives a bit of a picture of how we're going. You can't see it on that, but essentially we hit our stage 1 recruitment for the MRI phase about 2 months in advance, so 2 months earlier than anticipated, which is pretty good. These are the sites which are open at the moment. So there are over 15 sites signed up which are taking part in the stage 1 analysis. That's the MRI phase of the study. And we're hoping to open up another 15 sites over the course of the next 2 years, which will contribute to the phase 2 analysis, the part without MRI. It's also extended into Australia. So they've got their own arm, which has been named Platypus. And they're going to be feeding into the rest of this whole trial process. So it's now a multinational study. These are just some useful content links, and it's all obviously funded by the MS Society. These are some of the other collaborators and team members. Thank you very much.
Brilliant. Thank you very much, Sean. Does anyone have any questions for Sean?
Somebody who works in rare diseases, I'm trying slightly, but I suppose a question when you're planning and you're setting up something like this, is there I don't know in MS, but is there a core outcome set? Because I'm guessing that different drugs, will be perhaps targeting different mechanisms. So how do you account for that within your? When you mentioned 4 outcome measures there, CMRI and functional measures, but was
So-
that agreed ahead?
Yeah, so that was all agreed in advance. So thinking first about the clinical outcome measures, so that's immutable. That will not change over the course of the study, because you have to have, for the purpose of the regulators, you have to have one defined primary outcome measure. Those 3 all go together as a single event. So this study is designed as a time to event analysis. So it'll be if you have, predefined worsening in EDSS, time 25-foot walk, or 9-hole peg. Any of those things are a clinical event of your MS getting worse. In terms of the MRI, that's the part which is adaptive. So at the moment, all the evidence is that, this is the thing that will give us the most reliable information as to whether a drug is working or not. But the good thing about it is that the whole trial doesn't hinge on it and the regulator doesn't care about it. So if in the future we find a blood biomarker or a different MRI outcome measure or a clinical outcome measure that's even more reliable or even just cheaper, then you can shift it over to that and that's fine.
Yeah, any other questions? Yeah, go.
How do you decide whether you shifted, when you shifted, on what you shifted? How's it?
So there are predefined moments where it can be reviewed, and that decision would have been made well in advance by the overarching team that designed the trial, the MRC CTU. They would have laid that out very clearly with the regulators amongst the statisticians when they think about, all right, when are we able to go and review it again? Because otherwise, exactly, you could potentially just be chasing your tail constantly wanting to update things. But for example, like I said, this is a very long trial. It's going to go on for at least 10 years, probably a lot longer. And every year there will be other trials which are going to be reporting. And they will possibly report new effective treatments or new things that we need to consider, like how reliable an outcome measure is. And if there's something really, really important like that against a deadline, then fine, you can make exceptions. But generally speaking, it's all predetermined.
Can I ask a really quick question? So obviously I think your number of participants that you're seeking and kind of recruiting was a little bit mind-blowing. And part of that is because it's a platform study, I guess. But presumably even if it was just a sort of two-arm study, you would need large numbers of participants for to show an effect. And so that your starting point is also very high,
yes.
I presume.
Yes. So for most phase 3 studies, at least in progressive MS, let's say you're looking for maybe 1,000 participants, so quite a few. And part of the reason is because, again, I don't know generally how much familiarity people have with the EDSS, but it's quite a noisy measure.
Yeah.
People
in a way, it's quite surprising because it's not very sensitive. Like it's quite crude measure, I guess.
Yeah.
That we
but
feel.
Which is why then the other ones coming in actually make it more sensitive and make it a bit more robust. But the EDSS is what's widely accepted. You can't get away from it. Yeah. But then again, looking at that, if you're saying that you need 1,000 for all of those groups, but then if you've got one control, you can test that one control arm against as many other drug arms that are coming online at the same or roughly the same time.
Yeah.
Yeah. So it saves you a lot of participants being recruited even from that.
Yeah, brilliant. Thank you.
No
Great. So I'd like
Thank
to thank Sean and all of our speakers really for delivering fantastic.